Okay, I got it finally.
Welcome again, Dr. Bennett.
Yeah, I'll get them, hold on. Okay, I got it finally.
Welcome again, Dr. Bennett.
Yeah, I'll get them, hold on. Okay, I got it finally.
Welcome again, Dr. Bennett.
Yeah. Okay, let me get the other people in here.
Dr. Bennett, before starting, can we practice the screen sharing? Because I got this laptop new. I didn't use the Keynote system. Now I will share my slide on Keynote. Can we practice before the
Yeah,
start?
let's do it. Yeah, let's do it. Practice now.
Yeah,
Yep.
I click the share and I will choose the Keynote. Okay.
Okay, you're not clicking share. Because I can see you're not clicking share. You gotta click on share first. Go and share, and then you have a screen with 6 options. Just pick your PowerPoint. Are you getting the share? You see the share button? Do you see the share button? Oh, hello, can you hear me, Murat? You're muted. Oh, you fell out. Okay, there you go. You got the share. Now you have to put it on presentation mode. You have to experiment with that. You use Apple or yeah, perfect. You see how it is now?
Oh, okay.
It's good size. That's how it is.
Thank you very much. That's the first time in this laptop. I didn't use Keynote program before.
Okay. Yeah,
I have used
you do it once or twice.
PowerPoint slide.
You do it once or twice, you'll be fine.
Okay.
Okay.
Can you see my screen now?
Yeah, you gotta put a big screen, presentation mode.
Okay.
ONAT. It's press that button, ONAT. Oh, you see it? ONAT.
Or
There.
not?
Yeah.
Yeah, this
Press
is
button.
presentation mode. Yeah.
Doesn't that make it big screen? Click that. Click that ONAT. Yeah, you got it.
Yeah.
Okay, a few more minutes. So you have today off or you at the hospital?
Sorry, I couldn't understand.
You at the hospital now?
Yeah, I'm in hospital.
Oh, okay, in the call room?
Yeah, in my own room. Every day I'm come to hospital and see the patients. If there is a problem or if I have a operation, I stay 1 or 2 hours in hospital on weekends, and it's very hard and I have a very busy schedule nowadays. And today I learned this presentation and I prepare my slides and have a 10 or 15 minutes talk.
Okay, you can take as long as you want. It's okay.
Yeah.
Whatever. Uh,
Are you in Miami now or another country? Because I called you at 10 a.m. in Turkey time and you write a message to me. I think in Miami it's 3 or 4 a.m. when I text to you.
yeah. It's early. Neurosurgeon hours.
When you are sleeping,
In the day, and I try, like a doctor, I try to sleep in the day. But you know, as a doctor, it's difficult to sleep a day and work night. Your body, your brain is not programmed that way. Yeah,
I
but
always drinking coffee with maybe
yeah, I know. Without coffee, I don't think
here.
I couldn't make an intern. Being an intern, I couldn't without coffee. Forget it. No way. No way. Okay, we're ready to start. Let me announce it.
Okay.
Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good afternoon. This is Dr. John Bennett broadcasting from Miami Beach. Right here, we're very close to this beautiful beach. We have the honor of broadcasting another webcast from the Academy of Neurosurgery, a channel in Turkey. And today we have Murat Buyaktepe. He's a neurosurgeon from the Ankara University Department of Neurosurgery, and he's going to present on microsurgical principles and the management of supratentorial cavernomas. Welcome, Murat. It's all yours.
Thank you, Dr. Bennett. Good evening, dear colleagues. I am Dr. Murat Büyüktepe from Neurosurgery Department at Ankara University. Today, I will be presenting supratentorial cavernoma surgery, techniques, outcomes, and video demonstration. Supratentorial cavernomas is vascular malformation composed of cluster of thin-walled sinusoidal capillaries without intervening brain tissue, giving a characteristic Malbert appearance. Pathophysiologically, repeated microhemorrhages lead to hemosiderin deposition and surrounding gliosis, creating an epileptogenic focus. These lesions affect approximately 0.4 to 0.5% of the population, with a familial forms being rare. They most commonly presented in patients aged 30 to 40 years. 80% are located supratentorially, predominantly in the frontal, temporal, or parietal lobes. Clinically, around the half of the patients present with drug-resistant seizures, 1/4 with an intracerebral hemorrhage, and another quarter with a focal neurological deficits. On MRI, cavernomas display the classic popcorn sign, a heterogeneous core on T2 weighted imaging with a surrounding hypointense hemosiderin rim. T1 appearance vary according to age of the blood products. Gradient echo or SVI sequences reveal prominent blooming artifacts. Lesions are classified into the Zambrowski types 1 to 4 based on the hemorrhage age and morphology. Surgical resection is indicated for patients with a history of symptomatic hemorrhage, intractable epilepsy despite optimized anti-epileptic therapy, and progressive focal neurological deficit or mass defect. For deep or recurrent area lesions, radiosurgery or endoscopic approach may be considered. We tailor our corridor to lesion location, such as transsulcal cortical approach for superficial lobar lesions. This approach provides us with a short trajectory and minimal retraction. Transsylvial approach for insular or basal temporal lesions. It preserves vessels but a narrow corridor. Medial interhemispheric for paracollosal or cingulate lesions. It separates cortex yet limited exposure. Occipital posterior for occipital or deep parietal lesions. It provides excellent visualization with a visual pathway risk. Endoscopic trocar assisted for deep supratentorial targets. It's minimize the retraction at the cost of the steep learning curve. Key technical consideration include especially complete resection of the lesion plus hemosiderin margin to minimize the recurrence. Using of neuronavigation for accurate trajectory planning and intraoperative monitoring for real-time mapping of motor and sensorial pathways. Meticulous microsurgical dissection to preserve the normal parenchyma and maintain a clear plan. Transparent tubular retractor in a deep targets to reduce the retraction injury. Across the multiple series, complete resection must reach 90 to 98%. Seizure outcomes are excellent. Patients with a single perioperative seizure achieve nearly 100% seizure freedom, while those with multiple seizures achieves 75 to 80% seizure freedom. Morbidity remains low. Temporary deficits or infection occur in 10 to 15%, and long-term recurrence is rare, with most patients making strong functional recoveries. Now, let's review our edited 3 surgical videos. In this video, we demonstrate the microsurgical removal of the supratentorial cavernoma via transcortical approach. This lesion, exhibiting the classical mulberry-like appearance, was located in the deep white matter. Utilizing neuronavigation, intraoperative neurophysiological monitoring, we achieve a complete and safe resection. The transcortical route offers direct access to deeply seated lesions while minimizing the disruption by carefully selecting a corridor through non-eloquent cortex. This approach ensures, that's second video. This approach ensures maximal lesion removal with a preservation of neurological function. Surgical removal of the hemosiderin ring and gliosis also helps to eliminate the epileptogenic focus. In second video, we do the transcranial approach to again. Cavernomas, also known as a cavernous malformation, consist of cluster of abnormality, dilated blood vessels within the brain or spinal cord. Though often asymptomatic, they can present with a seizure, neurological deficit, or hemorrhage depending on their size and location. This case illustrates the microsurgical excision of the cavernoma using the transcranial approach. This route provides straightforward exposure, allowing the safe and effective removal of the lesion with a minimal risk to surrounding brain tissue. And third and last operation video is, in this video, we present the microsurgical resection of the thalamic cavernum in a patient who had previously undergone the gamma knife radiosurgery. Following the radiosurgical treatment, a pseudocyst development within a lesion, contributing to clinical symptoms. The patients presented right-sided extremity and partial paralysis. First, here we can see the sylvian fissure was dissected. Can skip this area. We use ICG for see the vessels. Here we use navigation probe to confirm the location. The location of the mass was confirmed using neuronavigation. The cystic component of the cavernoma was opened firstly and aspirated. This provides us with a space in the deeper structure, making it easier to dissect the mass from the surrounding tissue. Subsequently, we adherent tissue were dissected using bipolar forceps and aspirator and a micro dissector. The cavernoma was completely removed. I can skip this way here. Using the careful microsurgical technique, the cavernoma was associated kystic components were meticulously excised. Surgical removal of the hemosiderin ring and glias also helped to eliminate the epileptogenic focus. However, this is not always possible due to the risk of the neurological deficits and adhesion in the eloquent areas and the brainstem. We take it is totally. If you can do it by piecemeal, and after that you should take the glias tissue and hemosiderin tissue too. But it's not possible all the time. We can show the postoperative CT and MRI scan here. Postoperative imaging confirmed complete resection, demonstrating the effective of the surgery even after prior radiosurgical intervention. This case highlights the importance of the individualized surgical planning in deep-seated eloquent area cavernomas, I think. In summary, microsurgical resection remains the gold standard for symptomatic supratentorial cavernomas. Integration of the multimodal adjuncts, neuronavigation, intraoperative neuromonitoring, and when the appropriate endoscopic assistance maximize the safety and efficacy. I hope these videos accelerate your understanding of critical steps and fosters best practice in cavernoma surgery. Thank you for your attention. I would like to acknowledge my colleagues at Ankara University, and thank you, Dr. Bennett and Neurosurgical TV, for giving us the opportunity to share our practice. Thank you very much.
Okay, very good, Murat. Thank you very much for taking the time at the hospital to give this presentation. And I'm happy to see a neurosurgeon friend, Takashi Kan. He's a oncologist from Japan, and he's a big attendee of these webcasts. How you doing, Takashi?
Yeah, I'm fine, thank you. So I'm working the school to Mount Fuji. So thank you for the lecture. So I'm very interested to the cancer journals.
Thank you very much.
Yeah, Takashi, let me get off.
Yeah.
Let me get you off the screen share here. Hold on.
Yeah.
I'll get you off.
Okay,
Share.
I'm doing the screen sharing.
No, I get it. I get you off.
Okay, thank you.
Yeah. Takashi, it's good to see you. We're doing webcasts from Turkey. We're doing a series with Dr. Umid Eroglu from Turkey, and
Okay, yeah.
and Murat agreed to do a webcast today, and
Yeah.
tomorrow we have a webcast from Dr. Eroglu on robotics, and also Wednesday. So Tuesday and Wednesday we have webcast
Tuesday, Wednesday.
with
At this time.
Dr. Murat's boss, actually. He's the chair of your department, correct, Murat?
Dr.
Okay.
Erol is my professor. I am assistant professor at Ankara University now.
Ankara University. Okay.
I'm working with Dr. Erol in Ankara University and
Okay.
Neurosurgery department.
Is that where you're training, Ankara University?
Sorry?
Ankara University.
Is that where you're training, Ankara University?
Yeah, yes.
Ankara University. Okay.
How big is the program? How big is the program? How many residents you have?
How many?
Many
Residents?
residents, yeah.
Yeah, 60. 60.
60?
Yes.
What,
60,
10 a year?
too
10 a
many.
year? 10 a year? How many every year? How many in the first year?
Three residents at first year and five residents at second year, and the other one is 3, 4, and 5 years.
Okay.
Oh, okay. So it's a medium, not big, not small.
Yeah, medium.
And you see everything, obviously.
Yeah, I am working on cranial and spinal surgery for 5 years, and after that I will choose the one specialty area at neurosurgery.
Okay.
So cranial, you want to go into skull base as a specialty, or?
I want, but the time is show me which one is better for me.
Oh, okay. You don't have to decide now. When will you decide?
Okay.
On the assistant professor year, this is my first year in Ankara University.
Oh, okay.
And
So
I
you have some time.
choose one
Good.
after 3 years later. I will choose the one of the specialist.
Oh, okay. Okay, very good. You know, we now have dual neurosurgery lectures, you know, for neurosurgeons that practice endoscopic as well as open neurosurgery. It's called dual neurosurgery. Dual. Have you heard of that, Takashi? Dual.
Yeah, dual or hybrid. We call hybrid. Both.
Yeah. We're
Yeah,
doing that, yeah.
endovascular. Yeah,
Yeah, we're
endovascular.
doing that next Sunday at 2:00, 5:30
2 o'clock.
with Dr. Oto. Dr. Oto.
Ota.
Yeah.
Okay. Yeah, he's a hybrid neurosurgeon. He's also vascular surgery and endovascular.
Yeah, he likes dual. He likes to do
Yeah,
because they contend that you can't make a good decision unless you know both.
Yeah.
You make a decision whatever you do. Oh yeah, endovascular is best. Oh no, open's best.
Yeah.
So, anyways, okay, Dr. Murat, thank you very much.
Right. Thank you.
We hope
Thank
to,
you.
we'll see you, probably see you tomorrow.
Okay,
Yes,
see you
tomorrow. So,
tomorrow.
yeah,
Nice to meet you, Takashi.
Okay.
Nice to meet
bye.
you. Nice to meet you.
Nice to meet
Tokyo
you.
is a sanctuary. So after Yasuji, I will go to it. So yeah.